Hello, everyone. This is Dr. Jerry Cost recording this presentation in Davis, California. Point of care COVID-19 diagnostics. Our goal is to understand performance metrics and create new practice guidelines that will help us deal with the pandemic. Our learning objectives are, first, for COVID-19, to assess the outbreak and the need for point of care testing, to look at geospatial care paths and how they can help optimize POCT for infectious diseases. We'll get into mathematics a little bit. I do have an appendix with the equations and all the supporting information for you, and references are at the end of this presentation. Basically, we want to understand Bayesian performance metrics for COVID-19 diagnostics in low prevalence settings. And we'll discuss point of careology, a new concept out of Wuhan, China, where it all started, and try to integrate these with national policy and guidelines that enhance standards of care. We're familiar with the Ebola epidemic in West Africa. It was devastating with monumental numbers of deaths, as you can see, and 40% mortality. And now it continues in the Democratic Republic of the Congo. But the basic concept is to isolate the patient. And you can see for COVID-19, we're waiting for that vaccination to arrive to help us out, help us deal with the pandemic. But until then, point of care testing can be quite an aid. And in fact, in Africa now, these are some pictures from the DRC, where you see an open laboratory. High risk though. Some of the tests that are used in the upper right and the lower left. And then if you want to really get into this, this is the lab we built in several hospitals in Southeast Asia, an isolation lab that includes point of care testing you can see in the biosafety cabinet there. And then in a totally controlled laminar flow room with appropriate ins and outs and changing stations to keep everybody safe. Let's head for learning objective 1, COVID-19, to assess the outbreak and the need for point of care testing. I was in Southeast Asia when this began. I was shocked to see in Thailand, for example, that at the very onset, the first case outside China hit northern Thailand, people started wearing masks universally. Nobody asked them to, nobody required them to. They just have a culture of caring for others. And that's part of the story I'll present today in the concept of point of careology, a new discipline, a new physician, a new creation in China. And it is a little bit before its time, but then not totally implemented in time to help deal with this whole outbreak and epidemic. Professor Liu is in Wuhan, China. It's incredible that they put these SNAP-2 hospitals together in such short order. And there was incredible panic as well in the ERs, with initially a high death rate even among healthcare workers. This is the way the outbreak spread around the world, and unfortunately it came right to our area, very close to where I'm recording this talk, by way of the cruise ships. We saw the direct first community transmission in Vacaville, California. It's only about 10 or 15 miles from here. My hypothesis is that somebody from the cruise ship with stealth transmission, that person quarantined, left the group, ended up sick in a hospital, as you can see on the left, critically ill patient in the Vacaville Hospital. But this patient, the first community transmission case, was not in isolation and not tested, exposed everybody. Patient was transferred to our hospital, UCD Med Center in Sacramento, but then in the top right, as the flow goes over to the right, the CDC bumbled around and we really didn't have a diagnosis on this patient for some time. And here I presented in the lower right the prioritization the CDC had initially for tests, but in fact, no tests were available at UCD Medical Center. Sacramento County, or the California State Public Health Library. Well, then in general, we've come to see the usefulness of the point of care concept in that people will collect specimens for screening, evaluating in safe environments of drive-up, drive-ins, drive-through, walk-bys, pop-ups, and all these kinds of different things. And we really, in this kind of setting, want to assure the highest possible test performance with excellent positive predictive value and negative predictive value. Now, we're very concerned, of course, about positive predictive value. That's the post hoc view of the doctor who, when he or she receives a positive, has to decide, is it for real? Is it something I can count on? And if we did have and do have those high performance tests, we can relieve hospital infrastructure. We can help, I hope this year, with some multiplex concept, differentiate what will be our seasonal flus of ordinary influenza A, B from COVID-19. That's going to be a tough challenge in fall and winter. And then we need this kind of testing, of course, to discover transmission, to accelerate molecular diagnosis, triage, isolation, decision-making for patients infected with the virus. And there are many other aids that point-of-care testing can provide, such as monitoring so-called happy hypoxemia using fingertip pulse oximetry, diagnosing bloodstream pathogens, staging patients with pulmonary infections, measuring arterial blood gases, and somewhere along this line, we'll see actual measurements of viral loads in relation to pharmacological treatment. Well, we published this paper on point-of-care curriculum to make all the tools, educational tools, that is available to people, particularly in the schools of public health. This was published in Frontiers of Public Health, and you can see the topic outline here. And then another paper, also published in Frontiers of Public Health, to focus on the geospatial aspect of this, giving a toolbox that includes how to operate in a small world network, space-time transformation, spatial care paths, and on down the line, you see the contents of this paper on the left. And this is our learning objective 2, geospatial care paths. We want to optimize wherever we use POCT in a geospatial strategic fashion for infectious diseases. And now the public health profession has these 2 resources in Frontiers in Public Health, and more is coming this summer. I'll address that later. Well, when I was in Thailand, as soon as this thing hit, which was very early, winter, spring, increasingly, it became known as it spread that it was causing adverse personal, societal, economic, and cultural impact. And everybody was caught off guard. Nations basically weren't prepared for a pandemic. Nonetheless, point-of-care strategies can mitigate risk, reduce harm, and improve crisis standards of care. On the left, you see what occurred immediately in Bangkok, temperature monitoring. Well, that's a form of point-of-care testing, I suppose, and the device is on the right. But the point I want to make here is that POCT is inherently spatial. That is, it is performed at or near points of need, and also intrinsically temporal, because it produces fast, actionable results. Now, that's a big help when it comes to operating in a small world network, and this is your typical network, perhaps in the United States, but for sure the small world network of a limited resource country. In these settings in the upper left, and then cruising around to the bottom left, you can see we have primary care units. We can do fast point of care pods, and drive up ins and throughs. And I think we should be providing free COVID-19 POCT from home, primary care, and community hospitals, anywhere, emergency rooms and referral centers, basically wherever it's needed. This complex drawing will be published in a paper. It is a set of papers I'll introduce later in the Archives of Pathology and Lab Medicine. And to the right on the red dots, you see a critical path, which is very slow. This is what happened in China and in the United States when the outbreak first hit. Basically, molecular diagnostics were not readily available. Some companion tests came in, they were helpful, CBC and DIF. These can be performed by point of care testing devices. We've learned since then that D-dimer and IL-6 are related to this in a substantial way that can help differential diagnosis. But in China, the so-called coronavirus pneumonia was at first assessed by doing chest X-ray and CT scan to make a presumptive diagnosis. And then at the bottom right, you see that we are on this slowest path, losing a lot of time, high risk, a lot of fatalities, exponential growth of the outbreak, because we have to send these specimens to a laboratory for testing, and there's a lot of delay there, and there can be stealth transmission and all sorts of bad things happen in the meanwhile. On the left, it's more of the scheme that happened in the Silicon Valley with Stanford leading the way, really, with express care, point of care testing, obtaining specimens in a drive-through situation, looking at the patient, evaluating whether the patient needs further care, definitive diagnostic evaluation, and of course, in the center, if the patient is critically ill with pneumonia, ARDS, and hypoxemia, ends up in an isolation room unit or dedicated alternate care facility to deal with all of the intricacies of a critically ill patient and a fairly high fatality rate. On the left then at the bottom, we see for this different strategy, geospatial, because it is involving different spots in space and time, that it's really a faster path, and we need the accurate diagnosis. It's better for providers and safest for the population. Well, I mentioned that there will be new focus issues coming, and they're in Archives of Pathology and Laboratory Medicine. This particular diagram will be on the cover of the first one in October. Dr. Adel Khan at Temple University has spearheaded this project. He is the editor-in-chief for 2 special issues, and we're certainly pleased that he was able to do these since all of our national and international meetings have been canceled. But we're still getting the educational word out. And the idea of this schematic is that on the left, we go down a so-called spatial care path with a symptomatic patient, rule out the disease as quickly as we can with a very, very high performance test. We'll get into that momentarily. But we run the risk, as you can see in the middle, that there might be false negatives. That would be very painful because those people have the illness and they can spread it. But if not, then patients would be aggregated into an alternate care facility. In some cases across the United States, this is what has happened as we have dealt with the crunch of overload like in New York City or other sites. And even here in our local area, there's a softly built, which means ready to go but not open, facility to handle overflow if necessary in the state of California, which hasn't done very well. And this happens to be in a sports arena, set up and ready to go but not yet used. Well, we need to talk about the math. I don't think that people should be in these incredible lineups in their automobiles, waiting for results. I really think that it would be better to give everybody an opportunity, full access to home testing with high performance POCT, immediate results, and cloud reporting. Whether it is for primary diagnosis with some sort of molecular diagnostic concept, or it is in follow-up to see if there are antibodies and presumed, but not necessarily unequivocal, immunity to this disease. So in order for this to happen, we have to assure the tests are highly accurate. Now here's the problem. At very low prevalence, you see on the left a prevalence of 2, 3, 4, 5%. With the current specifications, that is, of the FDA emergency use authorization and also Health Canada minimum specifications for COVID-19 tests, a sensitivity of 90% and specificity of 95% is required. Now I've derived equations to plot the ratio of false positives over true positives, and you can see that when the prevalence here toward the lower left is 5.3%, the number of true positives equals the number of false positives. The predictive value is 50%. Well, what is that good for? Not much. And if you go to the lower prevalence of 2%, you can see that there are 49 false positives for each 18 true positives. In the upper right, I plotted for you the ratio of false negatives to true negatives, and this becomes relevant when the prevalence gets very high. And true positives, that is, people with the disease, tend to crowd out the statistics for the rest of the program. The next slide shows you a tier concept that I'm proposing that would categorize our test as 1, the EUA sort of thing at 90, 95, a better test, but still marginal at 95 sensitivity and 97.5 specificity, and then a high performance test at 100% sensitivity and greater than or equal to 99% specificity. That's tier 3, that really is the best. It may seem that, wow, these are incredible expectations, but in fact, as you look at the curves, tier 1, 2, 3 on the left, you'll see that they get pushed down as you go up the tiers and insist on higher performance. The inset here then to the upper right shows you how the 3 tiers perform over the entire span of prevalence from 0 to 100%. And on the vertical axis, we have percent for positive predictive value, that's just to the left with tiers 1, 2, 3 as you go up. Negative predictive value, tiers 1 and 2. The rate of false omissions, tiers 1 and 2 on the right, and so on. And you kind of get the whole big picture here. You know, the only place these tests are really going to perform pretty well is the prevalence is around 50%. And in fact, below 20%, one cannot expect most of the EUA cleared tests that are out there to work that well. Okay, what do we do? If you want to design a test, in other words, you're a doctor, you're an engineer, or bioscientist, or whoever, you can go to this type of graph, which is a plot of positive predictive value versus specificity. Go to number 1, select the positive predictive value you want. Suppose it's 90%. That's step 1. Follow across the line. Suppose my community prevalence is 5%. You know, that's not uncommon at all right now. Test positivity rates may be higher than that. Some states like California want to lock people down if the test positivity rate is 8% or higher. But in any case, the net prevalence out there is still quite low. So suppose we have number 2, an input prevalence to this model of 5%, then we need, going down number 3, a specificity of 99.4% in order for the test to really perform well and give us a positive predictive value of 90%. Okay, you can argue the whole scheme here I'm presenting, and I hope there will be interesting questions that come up. But the facts of life are, this is the way the math says the story will be. It's a little bit hard to argue with the math. And in order to get the total picture here, I'm proposing a new concept called predictive value geometric mean squared to give you a visual pattern from 0 to 100% prevalence that compares these 3 tiers. And of course, you could put any test you have on here and see where it would fit into the tier concept. So in the upper left here, we have 1, 2, 3 tiers. As the performance gets better and better, we move the curves up to the left, and there is an assay there with a star, which is a commercially available detection assay based on molecular diagnostics that performs really well, but it also has very high specs such as sensitivity of 100% and specificity of 99.8% plus. And in fact, that's what I think we really need. True excellence in point of care testing across the board with no excuses for anything less than that. Point of care testing is not an excuse for inaccuracy. Well, let's just take a quick look at this new concept called point of careology. Professor Liu and the team in China and I published this in Point of Care. You can see the reference in the bottom right. The concept is a new practice basically that enhances standards of care because one person will have the ability to test, to diagnose, to get a result immediately, no waiting, no automobile lines, no terrible inefficiency, no wasting of people's time. Can be done anywhere. The point of careologist goes to the home, goes to primary care, wherever. It's a physician, a nurse, somebody who is trained and prepared to deal with the whole situation as best they can. They're either going to triage and immediately send somebody based on real evidence from a highly performing test, send that person to the correct place and put them in quarantine or whatever it takes, or tell them, hey, you have antibodies and you can go back to work, probably, but at least you know where you stand. So we feel that this kind of concept can lower left, empower people to self-test, wear masks, trace their contacts among family and friends, and care for others. It's just too big a world, and we're not going to be there maybe for 40 or 50 years where we have this kind of concept fully played out. But what we do with it, point of careology practice for COVID-19, and I've given an example of influenza A and B, this is going to be a nightmare this fall and winter if we don't have a multiplex test that can help us differentiate these two illnesses. Kids are going to be getting sick, adults will be getting sick with flu, just standard old routine stuff. Well, do they have coronavirus or don't they? I think we should have a multiplex test cluster that detects, that's the upper area, highly infectious diseases directly, and tests also for immune response. Combine that with enhancing the differential diagnosis with point of care companion tests, the ideal world then, and perhaps throwing in artificial intelligence to augment our outbreak geospatial analysis. Well, this scheme shown here puts it all together. We need to really train people in public health. When we did a survey of public health schools in the United States, we didn't find any that had as a regular required part of their curriculum courses and instructions, or at least the labs and point of care testing. So our public health profession really is not prepared. They're not trained to deal with point of care, but it's the tool they need to deal with these outbreaks. And when they start becoming pandemics, of course, it's an absolute necessity. Who would disagree with that? In this flow then, the new people, the new point of careologists and these others meet the needs. They meet the expectation of people that want to go back to work, that want a diagnosis. This is the point of care culture that's upon us now. They are cognizant of dynamic evidence-based standards of care. In other words, this math thing where, my God, the math I'm presenting you today is a static picture of it all, but you know, the prevalence is changing all the time, and that will change the efficacy of particular tests if they're low performance tests. If they're very high performance tests, then they will tend to be a little bit immune, if you will, to the changes over time in prevalence, because the performance is good for any prevalence. But somehow we have to get to a sustainable business model so that startups can deal with this. We really need that global funding. We should probably have a global fund that supports all this so that innovators and inventors can create point-of-care diagnostic tests. And I would certainly like to see the nation have policy and guidelines to help this happen. So that's the end of the program, and I do have an appendix. These are the equation sets. I'll just show you quickly. I do have a plot for recursive testing, one to tell you, given a false positive rate, what positive predictive value, and here are the references. Thank you very much for your time and energy. I really appreciate your attending and listening to the lecture, and have a really great day.